Welcome. I'm Dr. John Stone, the Executive Chairman of IgG Forward, and it's a great pleasure to welcome you today to our second fireside chat for patients. I believe that our foundation is going to do many important things for patients with IgG4-related disease, but there's really nothing that will be more important than this, and that is to help educate our patients and their loved ones about IgG4-related disease, and that's the purpose of these fireside chats. So here's our agenda for today. I'm going to begin with a few announcements, and then Dr. Corey Perugino, my colleague at MGH, will join us to talk about the science of IgG4-related disease. Following Corey's talk, I will spend a little bit of time talking about how we are translating those scientific breakthroughs into clinical trials, which we hope will lead to new and better treatments for patients with IgG4-related disease soon. Then we're going to spend a lot of time answering your questions, doing our best to answer your questions. Thank you for all of the questions that you have submitted. We're going to try to get through all of them, or almost all of them that we can fit into this session. So thank you again for being here. Here is our guest, Dr. Corey Perugino, and his family of 4 kids at the beach. And Corey was at the beach very recently and actually pre-recorded his talk because this fireside chat conflicted with winter break for his kids. I want to begin by reviewing our mission statement at IgG Forward. Our mission is to improve the lives of people living with IgG4-related disease through education, expanding disease awareness globally, facilitating groundbreaking research, and being the trusted source of truth for patients with IgG4-related disease, their caregivers, and healthcare providers. So let's move on now with announcements. Just a moment, I'm having trouble advancing my computer. Okay. First announcement, I am delighted to announce that we have a director of patient advocacy, and she is a star. Catherine Provencher is a neighbor of mine in Connecticut. I live in Massachusetts, and Catherine lives with her family in Connecticut. She is a licensed social worker. She has worked in public schools for more than 20 years as a social worker, and this has really prepared her very well for this job. She is also the wife of an IgG4-related disease patient. Her husband, Andy, has been a person living with IgG4-related disease for the past several years. And here is a picture of Andy and Catherine. Catherine and Andy I have 3 young boys, so Catherine really does have her hands full, but she has more than enough energy to take on the job of Director of Patient Advocacy for IgG Forward, and she is already doing a wonderful job. More about her soon. We will be publishing an interview with her through our social media platforms, so stay tuned for that, and welcome, Catherine. Catherine is going to be leading 2 caregivers conversations over the course of this year. These are analogous to the fireside chats. I'll show you the schedule for the fireside chats for the year in a moment. But Catherine's going to lead 2 caregivers conversations because we know that IgG4-related disease is not only about being a patient with IgG4-related disease. Being a patient with IgG4-related disease means that one's entire family and friend network can be affected. And so Catherine is going to address not only patients, but also caregivers with these two conversations. The first one will be next month. It'll be a caregivers roundtable featuring Linda Bamber, who is a member of our board and a caregiver herself. Josh Argall, our colleague at Patient Advocacy Strategies, who is a caregiver himself, and Sabrina Riddle, a patient with IgG4-related disease. And we may have some others join that conversation as well. But put that on your calendars now for March 22nd. We'll be socializing that on social media as well. The second caregivers conversation will focus on the impact of IgG4-related disease on mental health. As a social worker, mental health, of course, has always been a big focus of Catherine's, and she is particularly tuned into this problem when it comes to IgG4-related disease. I think that's going to be a very powerful presentation, and we will finalize the date and let you know about that soon. With regard to fireside chats, this is really our second formal fireside chat. We did have an event back in November that is also available as enduring content on our website. That was a conversation between me and Professor Wen Zhang about the challenges of glucocorticoids in patients with IgG4-related disease. But our first formal fireside chat was back in December when I was joined by Emma Culver and Arazu Khosrowshahi. I should note that Wen and Emma and Arazu are all members of our advisory board. We had a very successful kickoff fireside chat with Emma and Arazu. Today, Corey's going to address the science of IgG4-related disease. Corey is also on our advisory board. In April, late April, precise date to be determined, Dr. Emanuele Della Torre from Milan will lead an IgG4-related disease symposium recap. The 5th International Symposium on IgG4-related disease is going to be held in Milan. Emanuele has organized it, and he will lead a summary of that meeting for patients. Then in July, we're going to focus on the pancreas with a gastroenterologist, Professor Matthias Löhr, who is the chairman of gastroenterology at the famed Karolinska Institute in Stockholm, Sweden, will join us. And Guy Katz, my colleague at MGH, who is doing some very exciting research in IgG4-related disease related to the pancreas and other things, will lead that discussion. Our final fireside chat for the year, the topic for this remains to be determined. We'd be happy to hear suggestions, so let us know through the website what you would like us to focus on. Along the lines of announcements, the 5th International Symposium on IgG4-related disease is occurring in Milan. As I have mentioned, there are more than 100 abstracts presented to this meeting, which we have reviewed. We have selected the ones that will be presented at the meeting, some of them in formal talks, others in abstracts. And I can tell you that the science that is coming down the pike in IgG4-related disease is really inspiring. And this is stuff from all over the world, from China, from Japan, from Europe, from South America, and North America. Really exciting things going on with regard to clinical issues in IgG4-related disease and scientific issues in IgG4-related disease. February 29th, Thursday, is a red letter day. It is Rare Disease Day. And this is the first chance that we get to participate in Rare Disease Day as the IgG Forward Foundation. And because of this day and because of everything that is going on in IgG4-related disease now, the Alliance for Patient Access, which is a nonprofit organization in Washington, D.C., helping to ensure that patients get adequate access to new medications, is already helping to take our case on. And with the help of a number of those on our advisory board and others, have created a white paper, which is entitled Addressing Access Barriers for IgG4-Related Disease Patients. We're going to be talking about clinical trials over the course of this fireside chat, and we hope to have approved medications in the next year or two. Presently, there are no approved medications for IgG4-related disease. Access will be something that we have to tackle, and we're already beginning to anticipate that and create strategies around that. We'll talk more about Rare Disease Day when we get into the Q&A session. But I want to remind you about our website. Many of you have logged on um, uh, to the Fireside Chat through the website and go to the website frequently. It is continuously updated. And we have multiple new videos about some specific organ involvement content and about IgG4 related disease in general. So I invite you to go there frequently. It's our goal to update the website on a regular basis, and there is still a lot to be done in that respect. We will be creating, and this will be coming to you very soon, a guide to identifying an IgG4 related disease provider across the world. We have lists of more than 1,000 physicians who are experienced in IgG4 related disease, and we're putting that together in a list for you that you will be able to access easily and hopefully facilitate your finding the right person to help you with IgG4 related disease. And the final announcement, I think, is I want you to watch this space, our website, for something really big that is coming late March, maybe early April, something really big. I think you'll be very excited about it. It's going to be great for our community. And now I will introduce Dr. Corey Perugino, who is a wonderful colleague and friend, and really the best translational scientist we have in our rheumatology division at the Massachusetts General Hospital. Corey trained in medicine at the Cleveland Clinic and came to MGH for his rheumatology fellowship. He had never set foot in a basic science laboratory until the day of his interview at MGH. And over the course of his fellowship and a number of postgraduate years in the laboratory of Dr. Shiv Pillai, Corey has become a wonderful scientist, and he is now an NIH-funded investigator who has opened his own lab, and he's going to continue to do great things in IgG4 related disease. There are a few take-home messages from his talk that I will give you in advance. The first thing that we want you to understand is, despite the fact that this disease was unknown to anybody 20 years ago, we actually have understood and learned and understand a great deal about IgG4 related disease. Number two is there are really good scientists working on this problem. And it's not only in Boston, not only in the United States, there are really good scientists and investigators all over the world focusing on this now. We're moving fast. The third message is that IgG4, and I think Corey will make this abundantly clear, does not cause the disease, but it is a very good biomarker. And we'll get to that again when we get to the question and answers. IgG4 doesn't cause the disease, but interactions between different immune system cells are the things that drive this condition. And our ability to understand this and how to manipulate this and how to suppress certain areas and upregulate other areas will, I think, allow us to control the disease very nicely and lead to better patient outcomes. And finally, this rigorous science is translating into potentially better treatments right now, the development of rational therapies. So without further ado, I will turn it over to Corey and let Corey take it away. I'll stop share and take it away, Corey.
So I thought we'd start by, just orienting what is IgG4 related disease. Many of you watching this know more what this disease is than I do because you're directly dealing with it. You experience it firsthand. These are a collection of images and in CAT scan images and clinical photos of patients that I've seen over the years that also struggle with IgG4 related disease. And over the history of medicine, many different diseases have been described as great masqueraders, meaning they take various different manifestations or forms and present in different ways. And I think IgG4 related disease really fits that bill as well. I'm mentioning here that it's a disease that wears many masks. And I think if many of you were in the room together, you would probably attest to that. I'm showing a photo on the top left of a patient's lacrimal gland that's enlarged and inflamed. You can see it's kind of red and swollen here where the arrow is indicating. The orbits can be involved. This is really the place where the eyeballs are held, and there's structures within the orbit like muscles that allow us to move our eyes left and right and up and down. And these muscles can become inflamed. You can see the enlargement of one of the extraocular muscles here where the arrow is indicating. And this disease can cause unusual manifestations too, where soft tissue and inflammation can build up in between the bones of the face. This is a patient of mine where you can see swelling right underneath the eyelid. It was really persistent and painless, which is often what this disease is doing. A classic manifestation of the disease is autoimmune pancreatitis. So we're seeing here a diffusely enlarged pancreas. The pancreas is encircled in this yellow oval. It's not an easy organ to make out. In contrast to the stomach, it's something like the stomach right above it. You can see this fluid level in the stomach. The pancreas is a bit more amorphous as an organ, and it's usually not this big. But when it's inflamed with IgG4-related disease, it's really diffusely enlarged, and this is what it appears like on a CAT scan. Come down to the bottom left. Many of you are familiar with the term retroperitoneal fibrosis. And you can see in this cross-sectional image of a patient's abdomen, I'll orient you. This is the liver and the spleen. This is the aorta running right down the middle and then branching. And these are the arteries going out to the two kidneys. And right around the aorta, you're seeing this grayish soft tissue, which really just shouldn't be there at all. It should really look kind of more black, like the neighboring tissue. So both sides here, this is just abnormal soft tissue accumulation. Really would represent a lot of immune cells, fibrosis, and scar tissue, which we'll talk more about. The blood vessels can directly be involved. So this is the aorta again running down the abdomen. And you can see kind of this wavy pattern, and the width of the aorta here really should be more like this in caliber. So you're really seeing this diffuse, it's called an aneurysm or enlargement or widening of the aorta. The bile ducts are commonly affected by the disease, and this commonly associates with autoimmune pancreatitis. And with the bile ducts, these are really tubular structures that can develop narrowed regions called strictures or stenoses, and that's what the yellow arrows are indicating. And if you follow where the contrast is here, it just kind of goes away right at that point. And this is an area where the bile duct has formed a stricture, again, from scar tissue and inflammation. And then lastly, one of the probably the most common manifestation are really the salivary glands. This is a patient of mine with submandibular gland involvement. And you can see I can wrap my fingers right around that gland. These are generally really diminutive glands, kind of hard to feel when they're normal in size. But when they're affected by IgG4-related disease, they're rather apparent. You can even see these in the mirror. So it's a disease that takes a lot of forms. And as you're seeing here, and as many of you have experienced, it generally is causing mass-like structures. So really, to understand what IgG4-related disease is, we really need to know what IgG4 is. And this is a common source of confusion for, I think, everybody. Immunologists, clinicians, rheumatologists, and patients alike. So I wanted to spend a good amount of time on IgG4 so we can all understand what this molecule is. Many of you are familiar with this from blood work results. You get plasma or blood levels of IgG4. Many of you and many of us monitor these values over time to understand what's going on with the disease activity. And then many of you may have seen these with biopsy reports. When you get a biopsy that suggests IgG4-related disease, often the pathologist will stain the tissue for IgG4 to understand how many cells there are expressing this marker. And I'm showing here some what are called immunohistochemistry stains. And essentially, anything that's dark brown in these pictures, like what I'm pointing to here, indicates a positive cell. So this is a cell that's expressing IgG. And then neighboring here, this is the IgG4 specific stain. So this is a type of IgG. And these dark cells all represent IgG4 expressing cells. Generally, these are not very abundant in inflamed tissues. But over time, with the chronicity or chronic inflammation, the amount of IgG4 can increase. And this is really what is expected in IgG4-related disease, in which we see a lot of IgG4 expressing cells that really begin to dominate what we see in the tissue. So IgG4 is a type of antibody. Everyone makes IgG4. It's really a normal part of healthy immunity. If we check anybody's blood work, we see some amount of IgG4. Most often in IgG4-related disease, that number is rather elevated. It could be mildly elevated and it can be normal, but more often than not, it's rather elevated. All right, so let's rewind on this even further and ask, what are antibodies? I'm showing a structure here of an antibody, in which you can see this portion down below that connects to a portion above it. And this purple area is called the heavy chain. There's 2 of those per antibody molecule. And then neighboring this, I put a pink structure here, which is called the light chain, smaller than the heavy chain and named accordingly. Antibodies are proteins that are made by our immune cells. They generally circulate in the blood, or at mucosal sites like in our nose or in the intestines. They deposit in tissues, and one of their main objectives is to defend us against microbes, kind of like the rest of our immune system. So if we look at the structure that I was mentioning before, the top portion here is what's called the antigen binding sites. So the heavy chain has a binding site, the light chain has a binding site, and there's overall 2 binding sites per antibody. And you may ask, what is an antigen? An antigen was really a term that was coined from some molecule that's able to generate antibodies. Right? So it's just an antibody generating molecule. It could be protein, it could be lipid like fat, it could be DNA or RNA. Really any macromolecule and biologic molecule can drive antibody production. And this portion down below that I mentioned initially, I really refer to this as the business end of the antibody for the most part. This is how antibodies interact with other cells in the immune system or other cells in the body. So you have one side of the antibody that binds something. Usually this is some foreign protein like a viral or a bacterial protein. And then once that binding occurs at generally at both sides, the business end or the Fc portion of the antibody then binds to receptors that are usually expressed by other immune cells. And this is how the immune system kind of communicates and talks to understand what's going on, that there's something foreign here, that there's something we need to cause inflammation to get rid of. So how do these antibodies work? So we're showing some antibodies here, and we're rolling out with arrows to different effector functions, how they have their effect and what they do. That top portion of the antibody that binds to antigen, the primary role there is just simply neutralizing. It binds antigen, so whatever that antigen is can't bind to anything else. So it just acts as glue, really. And I'll discuss more of that on the next slide. The other 2 things I'm showing here is clearing of microbes and killing of infected cells. And this is really mediated by this interaction between the business end of the antibody, or the Fc portion, binding to receptors that are on other immune cells. In this case, I'm showing a phagocyte. This is an immune cell that really gobbles up microbes. You can see it depicted here, a microbe that's inside the phagocyte. And down below, this is called a natural killer cell, another type of cell that expresses, natural killer cell here that expresses receptors for these antibodies. And they help by killing cells that are infected by viruses or bacteria. And then lastly, down below, again, mediating interaction between the business end or Fc portion of the antibody with another protein that's secreted during inflammation or expressed during inflammation called complement that just further drives inflammation. So you're seeing here that antibodies are kind of a middle zone between detecting something foreign and then driving an immune response against it. And that's really what the objective of antibodies is. So a main function that I mentioned initially in the last slide is neutralization, neutralizing antigen. And that's a real main function of interfering with microbes like viruses or bacteria. So I'll give you an example. Like many of us are more than familiar with now, SARS-CoV-2, or the virus that causes COVID-19. And many of us are, of course, familiar with the spike protein. We've heard of this through vaccinations and through testing to see if we have this infection. This spike protein is really riddled over the surface of the virus. And if I just put this in the scale, you can think of a lot of these small viruses that their real goal is to get inside our cells. I'm showing here an epithelial cell, which could be lining the nasal cavity or the sinuses or the intestine. And this virus wants to get inside so that it can really hijack the machinery of the cell and start making copies of itself. And viruses enter cells often by specific interactions. In the last slide, I was talking about antibodies interacting with receptors. This is another version of that, where there's proteins on the surface of a virus, like spike in this scenario, that binds to a specific receptor called the ACE2 receptor that's expressed on the surface of specific cell types, like this cells that line our nasal cavity. So this virus needs to bind to that receptor in order to enter the cell. And this neutralizing function of antibodies simply works by binding to antigen and interfering with that interaction. So that's really all antibodies are largely doing in the setting of this, protecting us against virus. So IgG4, we know it's particularly induced by repetitive antigen exposure. I'm going to give you a few examples of this. It's likely the repetitive antigen exposure seen with the disease, IgG4-related disease, that also results in the high IgG4 levels in the blood, as well as in these biopsies of tissues. So example one, this goes back 40 years to 1983 in a study of beekeepers. And these were novice beekeepers in the first year of their careers that were then followed for multiple years upon starting that career. And it's known that beekeepers develop antibodies against bee venom. And they're getting stung all the time, frequently, more frequently than most of us, just the garb that they wear. And they develop antibodies because these are foreign proteins entering their bloodstream. And these are 4 different patients. Some of them even have names published here. It's not something we do anymore, in terms of privacy. But some of these patients are even mentioned back in 1983. So you can follow this. This is May of 1978 to October, the following year in April, May, and then June a couple of years later. And this is looking at antibodies against the honeybee venom specifically. And you can see that there's some IgG1 early on when this person is starting as a beekeeper. That increases a little bit over the course of these 4 years. But there's almost no IgG4 upon starting the job. And this gradually and then precipitously increases over the course of those first few years of exposure to the antigen. And this kind of trend of some increase in IgG1, but a precipitous increase in IgG4 over time was seen in all 4 of these individuals that were studied here. All right, so this is one example of just chronic or repetitive antigen exposure, resulting in disproportionate amount of IgG4. So example 2 of this was more recently with the mRNA vaccines that were developed for COVID-19 against the spike protein of SARS-CoV-2. And you can see here against vaccine, or among vaccine recipients, before the vaccine, there was really this is IgG4 on the y-axis. It got cut off a bit. Before any exposure, there's no IgG4 antibodies. After the first dose, there's still none. A little further out after the second dose, still none. And then if you get your second dose and follow that further out, it starts to rise. And then after the third dose, it rises even more, and then persists over time in the circulation. So you're seeing you're needing multiple exposures over time before you start inducing IgG4 production. So these are really healthy and expected responses. This is how our immune system is meant to and has evolved to respond to antigens over time to build up IgG4. But one thought about IgG4 is that it really has an evolutionary role to work against and prevent anaphylactic or severe inflammatory reactions. This may be what's happening in IgG4-related disease too. So where do antibodies come from? So simply, they come from B cells that turn into plasma cells. Another name for plasma cells, a precursor to them, is called plasmablasts that I'll mention on a subsequent slide. So once a B cell, I'm showing in purple here, and these are all images taken from one of my mentors, Dr. Shiv Pillai, who's taught me a lot about this disease. So once B cells recognize antigen, one important thing that they do is they start interacting and communicating with T cells. Many of you have heard of T cells before. They come in different flavors as well. There's CD4 types of T cells and CD8 types of T cells. The CD4 types are those that really help B cells. They're kind of T cells or immune cells that facilitate inflammation in various ways. And one of those ways is by helping B cells become better at what they want to do. And what B cells want to do is make antibodies. They really want to differentiate into plasma cells and start secreting antibodies. That is how they have their impact on whatever they're defending us against. So I'm showing here kind of a complex thing that occurs within our lymph nodes when B cells are activated and when they bind to antigen, in which a B cell can go on and make a lot of copies of itself that you're seeing above here. And then with further interactions with other immune cells, like this type of T cell called a TFH cell, as well as interactions with dendritic cells, again, this is all occurring mostly in lymph nodes, these B cells can increase the affinity or the binding affinity or how good their antibodies, at this point, there's still receptors on the surface are, at binding to antigen. So it's really an education process that B cells can undergo after they're exposed to antigen. And during these interactions, the T cells give them some instructions on how to become a plasma cell or plasmablast. So this is really kind of a graduation process, an education followed by a graduation where B cells can differentiate and really change. You can see here the shape of a plasma cell. It's totally different than a B cell. The B cell, the nucleus is in the middle of the cell. It's almost the entire cell is nucleus. Once you become a plasma cell, the nucleus is relatively small compared to the rest of the cell. And why is this? Is because a plasma cell or plasmablast, it's really a protein producing factory. The protein it's producing is an antibody that it's secreting, but it needs all of the other machinery of the cell. You can kind of see in this depiction here that's involved in making proteins. So these plasma cells or plasmablasts differentiate. They can make copies of themselves as well, just like the B cells did here. And they start producing high quantities of antibodies. This is the same thing that occurs after people receive vaccinations. We have antibody responses, and then some of those can taper down over time. So let's get back to IgG4 related disease. Now we know some things, I'm familiar with some things related to antibodies and plasma cells. Now we can kind of understand what we see under the microscope with IgG4 related disease. So this disease is generally suspected or thought of by a pathologist when they see certain things under the microscope. So on the left, I'm showing you a cut section of an organ affected by IgG4 related disease. And one thing that quickly jumps out is you see a lot of these small purple dots or pixels. Each one of these individual purple spots represents an immune cell. These are mostly lymphocytes or plasma cells or plasmablasts. All of these things I was just mentioning. B cells are one type of lymphocyte. T cells are a type of lymphocyte. So you're seeing many, many lymphocytes and plasma cells just filling up these organs. And generally, a lot of these organs, like the salivary glands of the pancreas, should have very, very few of these purple dots. It should be really sparse in those. But instead, we're seeing a dense, thick amount of these cells infiltrating the organ. And they're really often, in this disease, embedded in a meshwork of fibrosis. This is scar tissue, collagen, that's been deposited in these organs. All right, so these are the two really kind of classic features of IgG4 related disease, in which we're seeing a lot of lymphocytes, plasma cells paired with fibrosis. And when those findings are seen by a pathologist, then they may say, I'm going to stain this tissue for antibodies against IgG4 and IgG to understand, is there a predominance of IgG4 among these immune cells and plasma cells? And these are the same pictures I showed you earlier. They're the immunohistochemistry stains where many of the cells are expressing IgG4. So we've studied a lot of these cells in the laboratory. We've looked at plasma cells and plasmablasts in tissues as well as in the blood. And what we see is that they really accumulate and build up in this disease. So I'm showing a submandibular or salivary gland from a patient with IgG4 related disease. CD19 is a marker of B cells. All B cells express this marker for the most part. And you're seeing many of these dark brown dots. Each one of those kind of hard to see with the resolution here, but there's many, many CD19 expressing B cells in the tissue. And a lot of these are expressing IgG4. CD20 is another marker that's expressed by most B cells. It's not expressed by plasmablasts that express IgG4 right above here, where you're seeing the IgG4, you're not seeing CD20, but you are seeing CD19. So what this means is that we have B cells kind of forming these aggregates, and then you have this rind of plasmablasts right above, or plasma cells that are making IgG4. And these markers, CD20 and CD19, I'll mention a few slides later related to some therapeutic targeting that we're currently exploring and some that we've have some experience with. This is showing plasmablast counts that are in the blood. These are generally not very common cells in the blood. This is measuring them as a number of cells per milliliter of blood, where you're seeing about 500 in a healthy control. In a IgG4-related disease, we're getting up into the thousands, sometimes as high as 10 or 50,000 cells per milliliter. So many, many of these cells that are building up. And what we've learned is that plasmablasts, or these antibody secreting cells, are responding to self proteins, not foreign antigens, as I've been describing. These antibodies are defending us against microbes and bacteria and viruses and spike proteins. In this disease and in many autoimmune diseases, the antibodies are really directed at the proteins that we make. So plasmablasts can be collected from blood samples, and through genetic sequencing, we can identify which one of those plasmablasts have made a lot of copies of themselves, suggesting that they're responding to some antigen. And then we can take those sequences that we learned from genetic sequencing, and we can express, physically make these antibodies in the laboratory. And once we make those antibodies, now we have a tool that we can really just go fishing with, in essence. And one way we could do this is by those same immunohistochemistry or immunofluorescence slides that I showed earlier. This is an example of a patient with autoimmune pancreatitis in which we found which plasmablasts had the most copies, like the purple ones here. We expressed the antibodies, and then we got some healthy pancreatic tissue from humans undergoing resections for pancreatic cancer. These were just the tissue on the side of those cancer that wasn't affected by the cancer itself. And we found that the antibodies bound really brightly to those tissues. Anywhere where you see green here is where these antibodies are binding. The blue dots are just the nuclei of cells as reference. So this is something that suggests to us that IgG4 related disease may be an autoimmune disease. We haven't proven this without a really good animal or mouse model to study that. But this is something that suggests that it's an autoimmune disease. And we're currently trying to understand this a lot more comprehensively. So we've identified some of the self-proteins that the immune response is targeting in the disease. And currently we're canvassing the entire, or close to the entire human proteome, which is all of the proteins. There's about 20,000 of them that each one of us express. And we're really trying to study all of them, as many as we can, to understand what antibodies are binding to an IgG4 related disease. So I'll orient you on this heat map here. The red color indicates how strong an antibody is binding, and the green indicates no or weak binding. And the top 30 rows here are 30 unique human proteins. The bottom 30 are a different set of human proteins, again, unique from the top ones. And the first 30 columns are plasma samples from 30 unique IgG4 related disease patients that are binding all of these 30 proteins that you're seeing in red very brightly. Whereas the columns 31 through 60 are plasma samples from 30 patients with scleroderma or systemic sclerosis, which is another autoimmune fibrotic disease. And that's a disease with known autoantibodies and what they bind to. And a lot of those known targets were identified down below, these red spots. But what we're seeing here is essentially that we're identifying novel antigens that have not been associated with other autoimmune diseases. We're associating them with IgG4 related disease now. And interestingly, we can really distinguish IgG4 related disease from other diseases solely by what antigens the antibodies are binding to. So more to come on this. This is really work that's underway in my laboratory as well as that of Dr. Shipley's. So we know that targeting B cells, it makes a lot of sense in this disease based on everything I've shown you here. And it works when we target B cells to treat this disease. So we have about a decade worth of experience of using rituximab in this disease. This is an antibody that targets CD20 on B cells, and it eliminates them. It kills B cells. This was from an open label trial, meaning that all of the 30 patients enrolled knew that they were receiving the medication, and the rheumatologist managing them knew that they were receiving it as well. And you can see that this is the disease activity score of IgG4 related disease, just kind of melt away over the 365 days. Usually this is occurring by day 30 or a few months after the infusion. Another more recent antibody or drug that's still in development right now is called obexelimab, and this binds to CD19 on the surface of B cells. In contrast to rituximab, it does not deplete or kill B cells as far as we know, but more so it inhibits or interferes with the function of those B cells. It prevents them from being activated and making copies of themselves. In a similar plot, we're looking at the disease activity score on the y-axis, and then over the course of this trial, again, 200 days out, we're seeing the disease activity across these 15 patients really melt down and reduce in response to this medication. This obexelimab is currently in a randomized and placebo-controlled phase 3 trial to really understand in a more regulated or controlled fashion how well it controls the disease. B-cell depleting approaches are also in development. So I mentioned rituximab. We've often been using this off-label. It's often very difficult to get this covered by insurance, and it's currently a barrier. We've seen this work repetitively, but it's often difficult to get payers to cover it. Another molecule called inebilizumab over here binds to a different protein that's on the surface of all B cells, like I showed you earlier, called CD19. And similar to rituximab, this eliminates B cells. So it's a B-cell depleting therapy. So we suspect it should work similar to rituximab. CD19 is expressed a bit more broadly on B cells than CD20, so it may even potentially work better. To be determined, and this is also in a randomized placebo-controlled phase 3 trial now as well. So summary and take-home messages. IgG4-related disease, as many of you know, manifests in many ways, including autoimmune pancreatitis, retroperitoneal fibrosis, and many other things like I showed photos of early on. The IgG4 molecule, it's not likely to be causing inflammation in IgG4-related disease. It's not really what IgG4 does in general, but rather it's trying likely to stop inflammation. So you can think of this as the immune system's response to the disease. It's trying to control it. And maybe it's doing a good job. Maybe without IgG4, the inflammation and the disease would be much worse. But it's likely having an anti-inflammatory role. That's the best to our knowledge. And then B cells and the antibodies they make appear to be targeting self and not foreign proteins, something that suggests an autoimmune nature to this disease. And lastly, targeting B cells therapeutically makes a lot of sense. From what we've seen so far, it does work well, but we still really need these final phase 3 controlled trials to demonstrate unequivocally that these approaches work so we can get approval for these therapies for patients. So thank you for being here again. And again, it's been an honor to get to talk to you about these topics today. And I'll turn the mic back over to John.
Thank you very much, Corey. It's a real privilege to hear that overview. I know it's a lot of new words, new vocabulary for many in our audience: antibody, antigen, IgG4, CD20, CD19, T cell. You may have to listen to it twice, but the most important take-home messages really are that all of this wonderful science, and we are fortunate to live in an era when our scientific understanding is progressing so quickly and is allowing us to make great strides in developing new therapies. All of this rigorous science is leading to better therapies, and I really believe that. So I'm going to say a few words about clinical trials in IgG4-related disease. And thinking about this, I recalled a statement that one of my mentors said when I was a rheumatology fellow. One of my mentors, who was a very esteemed rheumatologist in the field back in the 1990s, said that there will never be clinical trials in rare autoimmune diseases. And he was speaking at the time of lupus and vasculitis because no one had heard of IgG4-related disease in the 1990s. You can imagine how discouraged I was as a young investigator who was interested in doing clinical trials in rare autoimmune diseases to have my mentor say this. Fortunately, my mentor couldn't have been more wrong. He was right about a lot of things, but he was dead wrong about that, because there have been lots of clinical trials in rare autoimmune diseases, in vasculitis, in lupus, and in many others. And these clinical trials have led to important treatment advances and revolutions in the way that we approach patients with autoimmune disease. So this is a clinicaltrials.gov listing. It's a website maintained by our government that lists ongoing clinical trials. And there are no fewer than 17 listings for IgG4-related disease. And these 17 different studies are studying 15 different drugs and approaches for treating IgG4-related disease, and this for a disease that no one had heard of 20 years ago. So I think this is remarkable, and my mentor, I think, certainly wouldn't believe it. I'm going to spend just a little bit of time reviewing for you the 2 phase 3 clinical trials that are going on now. Neither of these trials is complete. One has completed enrollment, the other is still in the midst of enrollment. Corey alluded to both of these, and I hope that you can see through the threads of his remarks about why it makes sense to be using these approaches. So this is a schematic diagram of what we call the pathophysiology of IgG4-related disease, and Corey has gone through a lot of the basis of this. But B cells, which Corey mentioned, we believe are presenting antigen, self-antigen. It's because IgG4-related disease we think is an autoimmune disease, presenting different antigens to T cells, which are elaborating different mediators that cause fibrosis and tissue damage. We think that the B cell, which includes plasmablasts, is a really critical cell in this disease. And both inebilizumab, an anti-CD19 monoclonal antibody, and obexelimab, the mechanism of which Corey discussed, target these B cells. So there's a lot of biologic rationale for thinking this will be an effective treatment approach. So these are the names of the two drugs again. So the trial of inebilizumab is known as Mitigate. It's the first randomized double-blind placebo-controlled trial across the world in IgG4-related disease. So it's very important to know that. And the design of these two trials, the Mitigate trial and the INDIGO trial, which is studying obexelimab, are really very similar. They start out patients on steroids, then patients are randomized to receive either the investigational medication, inebilizumab, or a placebo, and the patient's steroids are then tapered off over a period of 8 weeks. And the goal is to demonstrate that the inebilizumab is effective at maintaining disease remissions out at 1 year. The obexelimab trial is very similar in design. It's called the INDIGO trial. The drug is a little bit different from inebilizumab. It also targets CD19, but the business end of the molecule, as Corey referred to, targets a different protein on the surface of the B cell. And when these two proteins are bound together, the cell is downregulated. We don't have any basis for comparison to have a sense of which of these approaches might be better than the other. We would be very, very lucky if both of them are effective and both are ultimately approved to maximize our options for treating patients. So we'll know the answers to those questions in the next year or two. My mentor was wrong about the conduct of clinical trials in rare autoimmune diseases. The disease he was interested in was not so rare, rheumatoid arthritis. And another thing that my mentor used to say was that when we develop a potential therapy for rheumatoid arthritis that regrows perfectly normal hands, we'll only need a clinical trial of 1 patient, N equals 1. We don't have that kind of therapy really for any type of autoimmune disease yet. And for this reason, we need larger clinical trials that study these questions in detail. This is the way forward for us. And we're already well down that pathway in IgG4-related disease. So let's move on now to your questions. And thank you again for your questions. So question number 1, I noticed that rheumatologists seem to be the lead researchers for this disease. My pancreas bile ducts are affected by the disease. Are you able to provide care for GI patients? Great question. And let me just say that gastroenterology input in IgG4-related disease is often crucial. And emblematic of this is the fact that we have 2 wonderful gastroenterologists on our advisory board. I've mentioned both of them earlier in the talk, Matthias Löhr from the Karolinska Institute and Emma Culver from Oxford University are 2 very experienced gastroenterologists who take care of patients with IgG4-related disease. And there are many cases of IgG4-related disease where specific GI input really is very crucial. We also have a wonderful pancreatologist at MGH, Dr. Yasmin Barco Hernandez. She's been a wonderful addition to our group, and her insights really are critical to our discussion. So gastroenterology also plays a very big role. Rheumatologists are interested in multi-organ disease and have been more naturally perhaps the physicians to care for maybe a majority of patients with IgG4-related disease, but I anticipate we're going to have much more collaborative relationships with GI in the coming months and years. Gastroenterologists can do certain things that rheumatologists can't. Particularly, they can perform invasive procedures when needed to dilate ducts when there are strictures that occur in the bile duct, in the pancreatic duct, etc. As rheumatologists, we like to approach these problems, hopefully identifying them before they get to the point of stricture and treating them with medical therapy. But sometimes interventions like this are required. And in those cases, GI input is as absolutely essential. Question, what percentage of IgG4 related disease patients go on to become diabetic when the pancreas is involved? So here is a CT scan showing a classic case of IgG4 related autoimmune pancreatitis. We see here what the radiologists refer to as a sausage-shaped pancreas. It's large, edematous, swollen, actively inflamed. And then after treatment, which has been effective in controlling the disease, this is what the pancreas looks like. It's no longer inflamed, edematous, swollen. It is shrunken, fibrotic, and much smaller than the native pancreas was. And it's not surprising, therefore, that a lot of the patients who have experienced this kind of damage do not make sufficient insulin to achieve normal glucose tolerance. So we have some data about this questioner's question. What percentage of patients with IgG4 related disease involving the pancreas develop diabetes? These data were presented by Guy Katz and Liam Harvey, who's a medical student now, but was a research coordinator at our center, and Yasmin, whom I mentioned before. And they will be published shortly. They've been presented at the American College of Rheumatology meetings. But they analyzed 305 patients from the MGH, 39% of whom had IgG4-related autoimmune pancreatitis. So these patients were in a rheumatology clinic, and rheumatologists were the primary ones taking care of them. And what we found was that 47% of these patients, I'd say no fewer than 47%, a lot, had developed diabetes. Now, diabetes is a pretty common condition in the general population, but 47% is way above the percentage that one would normally see in the general population. 57% of these patients required insulin. 48% of the patients also had exocrine pancreatic insufficiency, and this is the other main function of the pancreas, to produce digestive enzymes that help us digest food and absorb nutrients. So patients with IgG4-related autoimmune pancreatitis also are at risk for failure of the pancreas in this regard. This is very high, and we need to bring these percentages far down through earlier diagnosis and better therapies. Another question, I have severe hydronephrosis. So let's tackle this one. This is a patient, and Corey, I think, showed the same image of a patient with retroperitoneal fibrosis. This is inflammation around the aorta here, running down the center of the body. And hydronephrosis typically results in when IgG4-related disease causes retroperitoneal fibrosis. Can you explain how I can be healed from that? So the issue is an anatomical one with retroperitoneal fibrosis and hydronephrosis. So this is a diagram of the urinary tract, the kidneys, and the ureters extending from the kidneys on both sides going down to the bladder. Here is the aorta. And remember that I showed you and Corey showed you that in retroperitoneal fibrosis, the inflammation is often around the aorta in this area here, also down to the iliac arteries once the aorta splits into the iliacs. The ureters cross the iliac arteries on their way to the bladder. And if there is inflammation in this area, the ureters get trapped. and they're constricted and urine can't pass. And that leads to the condition of hydronephrosis. This is where the anatomical lesion occurs. It can occur on one side or it can occur on both sides, and patients can develop bilateral hydronephrosis. The resulting backup pressure into the kidneys leads to damage and sometimes to kidney failure. So here is a CT scan showing this is a normal kidney here on the patient's left. We're looking up from the patient's feet toward the head. It's a cross-sectional view, left kidney here, right kidney here, and here is the large swollen ureter because it is blocked on its way to the aorta, leading to hydronephrosis. So what can be done for retroperitoneal fibrosis and for hydronephrosis? So there are medical therapies. Steroids are used and can be highly effective in some cases. B-cell depletion with rituximab is often used off-label. Mycophenolate mofetil is often used off-label. We do have some data about the effectiveness of rituximab in this setting. We studied 19 patients from our center who had been treated with rituximab and no steroids. This was back right before the pandemic started. All 19 patients had symptomatic improvement. That was very gratifying. And out of the 10 patients who had ureteral stents at baseline, 4 of them, or 40%, were able to get the stents out. And that is a huge therapeutic triumph when we're able to do that. But medical therapies don't always work, particularly if the problem is not identified until a very late stage. And in those cases, we have to think about interventions. Stents, as I have mentioned, or nephrostomy tubes. So let's look at stents first. I've shown you where they go in terms of the anatomy. This is a CT scan. Again, a cross-sectional view looking at the aorta here. Here is the rind of inflammation, the retroperitoneal fibrosis around the aorta, and you can see it reaching out and grabbing the ureter. That is actually a metallic artifact from the metal stent, which has been inserted into the ureter to alleviate hydronephrosis. This is effective when the stents can be passed, but it is uncomfortable, as you can imagine, to have metal stents in one or both ureters. So it's not a great long-term solution, and we always hope that medical therapies will lead to improvements. The stents, again, are inserted by going through the bladder, through the urethra, and then up into the ureters and bypassing the area of narrowing or stenosis. Sometimes the stenosis is so bad, the narrowing is so tight that the stents can't be passed. And in those cases, in order to alleviate the pressure on the kidney and relieve the hydronephrosis, tubes have to be put into the kidneys through the skin. This is a nephrostomy tube. This is a patient with bilateral nephrostomy tubes that she needed because she had bilateral hydronephrosis. I am so pleased to say that this patient got both of her nephrostomy tubes out after successful medical therapy, and her urinary tract function is entirely normal now, a wonderful therapeutic triumph. Sometimes medical therapies don't work, and stents don't work, and nephrostomy tubes don't work, and in those cases, we have to contemplate surgery. This is typically done by a urologist, and the type of surgery is called a ureteropexy. A ureteropexy means that the surgeon enters the retroperitoneum, typically with a laparoscopic or minimally invasive procedure, dissects the fibrotic tissue, dissects the ureter away from the area of inflammation, if it is possible to do that, and then pulls the ureter out and sews it to the abdominal wall to prevent the ureters from being blocked again. And this is big surgery, but it can be very successful and lead to the reconstitution of a normal urinary tract. So that is ureteropexy. Next question, again, about retroperitoneal fibrosis. Will the existing fibrosis dissolve with treatment, steroids and mycophenolate mofetil in my case? Or does the treatment just aim to prevent new fibrotic tissue from forming? The answer is hopefully both. It will help dissolve the existing fibrosis and prevent the formation of new fibrosis. But a little bit of information about RPF, which comes now from years of taking care of these patients. The fibrosis in RPF, fibrosis is scarring. It seldom disappears completely, even if we have effective medical therapy. Even if we achieve an enormous therapeutic success with medical therapy, the fibrosis seldom goes away completely. It's still there, maybe smaller, maybe a lot smaller, but the radiologist can still see it on imaging. But this is important. It doesn't take much improvement to lead to a huge clinical improvement. If we can achieve just a little bit of shrinkage of the fibrosis, we're often able to get the stents out, to get the nephrostomy tubes out, and have the patient return to a normal quality of life. We really need more work in RPF, in retroperitoneal fibrosis. It is a big underserved area in an underserved disease, but there is room for and reason for hope here. Can you share your thoughts about the long-term use of rituximab for treating retroperitoneal fibrosis? Certainly. First of all, if you've a patient who's got this and you have received an effective treatment, it almost doesn't matter what it is. If it has worked, you want to keep taking it so that the problem doesn't come back. But what we have learned is that if medical therapy works, frequent retreatment is usually not required. So it's really a matter of imaging the patient and making sure that the patient that the process doesn't seem to be creeping back. It moves very slowly. Making sure that it is quiescent through the use of imaging studies, and then retreat if and when it looks like the process is becoming more active. But it's typically quite slow if it comes back at all. Question, we want to avoid relapses. What can be done medically to prevent them? Well, there are a variety of options. In many parts of the world, patients are maintained on low-dose prednisone. Often it's not such low doses, 7.5 or 10 milligrams a day, month after month, year after year is not really a low dose, and that is associated with a substantial other set of complications, as Wen Zhang and I talked about in our Boston to Beijing seminar that we did, and which you can view on our website. But low-dose maintenance prednisone is one option to prevent disease flares. Regular B-cell depletion infusions can also be used. Mycophenolate mofetil is a treatment that, like rituximab and like prednisone for that matter, really has not been proven to work in IgG4-related disease and is not approved by regulatory agencies, but is often used to maintain disease remission. And then lifestyle interventions are the other possibility raised by the questioner. So a related question is there any factor known, medicine, diet, or lifestyle, that favors long-term remission? So you can see this is a question we get often, and so I do have a prepared answer. The questioner asks, I am certain. The answer is unknown. Well, it's not entirely unknown, but there is still much that we don't know. Is the efficacy of medicines known? Though things have not been proven in clinical trials, we have a strong sense that some of these things do work through multiple smaller, unrandomized, unblinded trials. It's clear, I think, that prednisone and B-cell depletion work well for many patients with this disease. But has the efficacy been well studied? Not yet. These studies are underway. And with regard to diet, exercise, vitamins, sleep, and other lifestyle things, no, there is no intervention that really has a known efficacy or has been particularly well studied. That's not to say that some of these things are not important. I believe that they are. I believe getting good sleep is important. I believe exercise is important. Heart-healthy diet is very important. But none of these measures are known to have a huge impact. Nevertheless, I don't discourage patients from doing these things. And on the contrary, I strongly encourage them. Does IgG4 related disease affect the brain to the point that it can affect that it can mimic Alzheimer's type forgetfulness? The short answer here is no. IgG4 related disease can affect almost any organ in the body, but the one organ that it almost never affects is the brain. It rarely, if ever, affects the central nervous system. So if there is a forgetfulness that is going on, there is another issue at play. There can be issues related to medications, which might impact cognition or thinking ability. But Alzheimer's-like dementia would not be expected to develop as a complication of IgG4 related disease. Have you ever seen any correlation between people with IgG4 related disease and increased occurrence of cancers? This is a very important question, so I'll spend some time with it and let you know what we know at the moment. First, the relationship between IgG4 related disease and cancer, if any, is really unresolved. It's an area where we need more study, and I think we're going to have much better answers related to this in the next few years. But it is important to remember that most patients with IgG4 related disease do not develop cancer. So I do not view IgG4 related disease as a pre-malignant condition. There's a lot of evidence to suggest that that is not the case. It does not inevitably evolve into cancer. If patients do develop cancer, it's not clear that the cancer is related in any way to IgG4 related disease. Colon cancer, breast cancer, prostate cancer, lung cancer, all of these are common in the general population, and inevitably in a large enough group of patients with IgG4 related disease, cancer may develop, but it's not clear that it's related to the underlying IgG4 related disease. It is true that inflammation, in theory, can lead to an increase in the cancer risk. And this is yet more rationale for maintaining IgG4-related disease under good control. But I can assure you that the links here between IgG4-related disease and cancer are not tight. So the upshot is that this is not something that you should spend time worrying about. Let us figure this out. Give us some time. We're working on this question hard. And while we're doing that, work with your doctor to make sure that you are following the regular cancer screening guidelines for colonoscopy, for mammograms, for PSA measurement and smoking cessation, and all of those things, which I think are a lot more important probably for preventing bad cancer outcomes. Question, does a patient need to have particular organ involvement in order to have a diagnosis of IgG4-related disease? And there are a couple of more sub-questions here. Can it be diagnosed simply with just high inflammation parameters in blood tests, such as high IgG4? And is a biopsy always needed? So these are all important questions. Let's take them one by one. Does a patient need to have a particular organ affected to have IgG4-related disease? And the answer is no. IgG4-related disease can affect just about any organ, with the exception of the brain, as I mentioned earlier. IgG4-related disease does tend to affect certain organs. In particular, it tends to affect glands, lots of different glands, which are organs that make hormones, can be affected by IgG4-related disease. In particular, the glands of the head and neck, the lacrimal glands shown here, the parotid glands shown here, and the submandibular glands under the jaw shown here. These are classic IgG4 related disease organs. The pancreas is also a gland, and probably about half of patients with IgG4 related disease have pancreatic involvement. The thyroid gland, the prostate gland, and the pituitary gland can all be affected by IgG4 related disease. But there are other organs too that are not glands that can be affected and are quite classic. So the orbits, the area around the eye, especially the extraocular muscles, can be involved. The lungs and the kidneys, the aorta and the blood vessels, the pachymeninges, which are the area, the tissues around the brain, not the brain itself, but the tissues around the brain can be involved, and so can the retroperitoneum, as we have discussed. So what about, can the diagnosis be made simply on the basis of a high serum IgG4 concentration? When we are sent patients with a very high serum IgG4 concentration, we ask 3 questions. Number 1, how high is the IgG4? Number 2, does the patient have a typical organ involved? Those typical organs are the ones that I just showed you. And number 3, is there another potential explanation? So a high IgG4 cannot make the diagnosis all by itself. These are data from a collaboration between MGH and Stanford, published just this last year. And Matt Baker and Zach Wallace and others showed that even if the serum IgG4 was elevated to more than 5 times the upper limit of normal, the diagnosis was not IgG4 related disease in about 25% of cases. So we can't rely only on serum IgG4 concentrations. There are a whole lot of other things that can cause an elevated serum IgG4 that are not IgG4 related disease. Allergy, eczema, asthma, and many other immune mediated conditions can cause elevations in serum IgG4. So we need more than just an elevated serum IgG4. Is a biopsy always needed? And the answer is no. If the clinical presentation is classic, one does not need a biopsy. We've gotten to the point in understanding the disease to know that if you've got this and this and this, 3 classic organs, and you have an elevated serum IgG4 that's quite high, there's really no biopsy that is needed. To make the diagnosis of IgG4 related disease, there is no single diagnostic test, but we consider information related to the clinical presentation, the serological findings, including IgG4, radiology information, and when available, a biopsy. One often doesn't need all 4 of these. If the case can be made strong enough simply on the basis of the clinical and serological findings, then no biopsy is needed. A biopsy is needed when there is uncertainty, even despite knowing the clinical information, the serological data, and what the radiologist can tell us. If there's still uncertainty about what is causing the problem, and there is a lesion that can be biopsied, then a biopsy is needed to rule out infection, malignancy, or another inflammatory condition. So I hope that is helpful in sort of summarizing our approach to diagnosis. In addition to IgG4 related disease, I'm also being treated for autoimmune pancreatitis, AIP, and interstitial lung disease. Are these 2 problems related to IgG4 related disease? The answer is absolutely yes. There is no question that autoimmune pancreatitis most of the time is IgG4 related autoimmune pancreatitis, and there's a long number of different manifestations of IgG4 related disease that can occur in the lungs. One of these is interstitial lung disease. So I think this is probably an issue of communication between the care provider and the patient. All of these are likely caused by IgG4 related disease. We'll come back to the lung when we get to the last question. Does IgG4 related disease interfere with normal immune responses independent of any medications that the patient may be taking, e.g. rituximab? So in essence, does IgG4 related disease make people immunosuppressed? And the answer is no. There is no evidence that IgG4 related disease leads in and of itself to immunosuppression. Any of these problems are the result of the therapies that we administer. Is rituximab use associated with worse COVID outcomes? And here, unfortunately, the answer is unequivocally yes. Rituximab is probably the worst medication to be on in the middle of a COVID pandemic. So it is fortunate that the large wave of COVID has moved through, but it's not through entirely. We still have to deal with it, and we'll probably always have to deal with it. So what do you advise patients about COVID precautions? This, of course, is a moving target, but I'll try to provide you with some guidance about what I tell patients. So first of all, it's critical to be vaccinated, to keep up to date with vaccinations. There is nothing more important for patients who are on immunosuppressive therapies, particularly B-cell depletion, to do. So what vaccines are important? COVID, shingles, zoster vaccine, the flu vaccine, the pneumovax, and RSV. These vaccines all save lives, reduce morbidity, reduce hospitalization, and save lives. It's very important to keep up to date on them. If despite vaccinations, you happen to get COVID, and almost everyone will get COVID at some point, if you do get sick, then you need to be treated. There's no question about it, no ifs, ands, or buts. If you are immunosuppressed with one of our treatments and you get COVID, you should be treated with whatever the prevailing therapy of the day is for COVID. Vaccination is critical, and I think it's important to emphasize that patients should still wear masks probably for 6 months after they have received a B-cell depletion therapy, if they're going to be out in a crowd at a time when the incidence of COVID is high. I've heard of IgG4 being elevated after repeated mRNA vaccinations. Any insight into this would be useful for the group to hear about. Great question, and Corey has already addressed this question in his remarks. Remember, he said IgG4 is induced by repetitive antigen exposure, and he showed this graph, which is the graph of patients who have received COVID vaccinations. After the first one, after the second one, there's no increase in IgG4. But finally, following the second one, there is a boost in IgG4 concentrations. And after the third, there's an even higher boost in the IgG4 concentrations. This is a normal response. This is expected. It doesn't mean that the patient has IgG4-related disease or active IgG4-related disease, and it will not cause an exacerbation of IgG4-related disease. It's a healthy response. We're happy to see that. How is the effectiveness of rituximab determined after an infusion? Great question. This is a paper we published in 2010, and now in retrospect, I realize that it really kicked off our current era of B-cell focused therapies for IgG4 related disease. You can see Arazu Khosrowshahi on our advisory board was the first author of the paper. This is a patient with very enlarged parotid glands, and 1 month after therapy, he looked like this. So this is one way you can tell whether the drug is working. The masses that occur in organs of patients with IgG4 related disease shrink. They shrink dramatically and they shrink quickly. So that's one way to tell. Another way is illustrated by this patient who had multiple organ disease. He had lacrimal gland involvement here. His submandibular glands were big. And he had really what we refer to as proliferative disease because he had multiple organs involved and very high serological markers. And these were his labs before he started treatment at baseline. He had a very high globulin fraction. This was almost all IgG4. His complement levels were very low, and he had a very elevated IgE as well. After treatment with rituximab, this is what happened. Very quickly improving with a decline in his overall antibodies. His complement levels normalized nearly within 1 month, and his IgE also came down very dramatically. And these improvements were sustained over many months. So we can follow markers in patients' blood very, very well to understand whether the therapy is working or not. It's not difficult to tell in IgG4-related disease whether an effective treatment is working. And these are the patient's serum IgG4 concentrations, almost 5,000. And after treatment, they declined continuously and slowly for many months. He was in a clinical remission for all of this time. Yet even 14 months later, his serum IgG4 was still high, although only about 1/10 of what it had been before he started treatment. How often do you see continuously increasing IgG4 blood test numbers, but no apparent clinical symptoms of compromised organs? Great question. This is a clinical scenario we encounter often. And what is recommended in such a case? And a related, almost identical question, should a patient be treated with medication if she has no symptoms? So some words of wisdom here learned at the School of Hard Knocks along the way over the last 15 or 16 years. First, a rising IgG4 level in the blood shouldn't be ignored because if it is rising steeply, it indicates that there is active disease somewhere. It may not yet be clinically evident, but a rising IgG4 almost certainly means that there is active disease somewhere in the patient's body. But the corollary to this is that it is not a reason to panic. IgG4-related disease is a slow-moving disease. And if you see that the IgG4 is rising, there is time to intervene successfully with treatment. There's no reason to press the panic button. Monitoring carefully after treatment can lead to early detection of recurrent disease activity and effective therapy before patients get into trouble. Here's an illustration of why it is important not to ignore a rising serum IgG4 concentration. This is a patient who lived far away in another state, so it was not easy for him to come back regularly. And he felt great, but his serum IgG4 was rising, and eventually he was found to have pituitary involvement and discovered to have pituitary failure. The pituitary gland is shown here. It's at the base of the brain, and it's very, very enlarged here. This was subclinical disease. The only hint was that his serum IgG4 was rising. And certainly had he been closer and had we been able to follow him more closely and measure his blood work and evaluate him more closely, we would have picked this up earlier. So next question, and again related, my IgG4 is normal now. When can I stop getting treatment and medication? Well, if you've had a serum IgG4 that was very high and now you have been treated and it's come way down and now it's normal, the answer is you've probably been treated enough for now. And this is because IgG4 is a very good biomarker. It doesn't cause the disease, but it is a very good biomarker, an indicator of whether the disease is active or not. And here is an example from one of my patients whom I showed at our last fireside chat. I've taken care of her for many years, and this is going back to 2018, and she was in remission after treatment and had normal serum IgG4 concentrations, but starting to rise and then continue to rise consistently over a period of 7 or 8 months. So I made the decision to retreat her again, and her serum IgG4 concentration came down very nicely. This was just in time, fortunately, for the pandemic. So she went throughout the pandemic without needing to be immunosuppressed and retreated again. But then, only last November, IgG4 was found to be a little bit elevated, and I didn't like the pattern I was seeing. So I retreated her again, and she remains in remission, and now her serum IgG4 concentration is normal again. So the IgG4 was very useful here as a biomarker, an indicator of whether the disease was active or not. As patients, what is the best way for us to spread awareness of IgG4 related disease? I'm glad you asked this question. I asked Catherine Provencher, our Director of Patient Advocacy, and Catherine indicated that sharing their personal stories with others is one of the best ways to spread awareness. Another way is connecting and collaborating with advocacy groups like IgG Forward, which can help to provide education, resources, and support. And Catherine collaborated with Kari Levezzi at Patient Advocacy Strategies to put this together. So on our website for Rare Disease Day, February 29th, we have this. This is Rare Disease Day, and we want to hear about your IgG4 related disease story. Visit the homepage of our website here at this URL and click the Share My Story button. When you submit your story, you'll have the chance to be featured, if you wish, on our blog or social media channels. Through sharing your experience, you can help educate others, advocate for better support and resources, and foster a sense of community among those also affected by IgG4 related disease. So we're getting close to time, and we're almost done with the questions. So next question. My submandibular glands became quite swollen after I had IgG4 related disease in 2017. They remain very swollen even after treatment and normalization of my blood test. Is it normal for these glands to remain swollen? So the submandibular glands, very, very common organ involved in IgG4 related disease, often don't completely normalize. They generally shrink pretty quickly, but they may not become completely normal. Sometimes they remain firm and hard compared to the softness that they had before patients got sick, but they rarely remain very swollen. So of course, it's difficult to interpret this without actually seeing the patient myself, but the very swollen concerns me a bit, and some further assessment may need to be done here. If a biopsy was not done before, for example, then it may be necessary to consider a needle biopsy of one of these glands. So this would be worth checking in with your physician again about. Can you please tell me if the central nervous system is affected by IgG4 related disease? As I've indicated, that it is not. The brain is not affected. And is fatigue a common side effect from the disease? The answer unequivocally is yes. Like any inflammatory systemic disease, IgG4 related disease can be associated with fatigue. To combat that, it's important to control the disease activity, to make sure you're getting good sleep, eating well, and getting exercise, and be patient. The fatigue really will get better if you can be maintained in remission, and make sure that these other points are being taken care of well also. What is the longest remission you have seen? I would say it's probably about 5 years, but our current therapies do not cure the disease. Patients, once diagnosed and treated, need to be monitored. And I'll give you some guidance about how to do that. So when in remission, how often to do lab work for monitoring the disease? So the answer is, I think every 3 to 6 months. The ideal is probably every 4 months when patients appear to be in clinical remission. And this is what we recommend monitoring. There are blood tests. IgG4 is particularly useful. IgG1, IgE, and complement levels C3 and C4 can also be very good markers of disease activity in some patients. Nothing is better, probably, in most patients than IgG4, and that should certainly be followed very closely. It's also important to monitor the function of certain organs. The pancreas function can be monitored by following lipase levels in the blood. Hemoglobin A1C is a measure of glucose tolerance, and an elastase measurement in stool, which can be a reflection of the exocrine function of the pancreas. The kidney function also needs to be monitored with a creatinine. These are all routine things that can be done quite easily and regularly, and this will lead to early detection of any problems. Does IgG4-related disease affect life expectancy? Well, this depends on how long it's taken to make the diagnosis and how bad the organ involvement is and how critical the organ is. But in general, if a patient is diagnosed early and effective treatment is begun, and then there is appropriate follow-up over time, I would not expect IgG4-related disease to impair life expectancy. But that is dependent on early diagnosis and good care and management over time. What is the best way, and this is our last question, what is the best way to monitor for recurrence of lung nodules? Some doctors say yearly x-rays, CT scans, or MRIs. Others rely on blood work, and others say don't worry unless symptoms recur, such as shortness of breath or tightness in the chest. What is best? So as I indicated earlier, the lung can have a large number of different manifestations of IgG4-related disease, and lung nodules is certainly one of them. The yellow arrows here are all pointing to abnormal lung nodules, collections of inflammation within the lung. And here is another example with some nodules, some of which seem to be resolving a little bit. They look sort of moth-eaten. The most important thing for monitoring these following treatment really is monitoring blood tests, typically. Blood tests will be the most useful thing to follow. Lung nodules take a long time to go away completely. They may not go away completely because they may just become scars that are going to be there for all time, but not cause a problem. Patients can have perfectly normal lung function, even with nodules like this. So it is possible to perform too much imaging. Remember that CT scans are associated with radiation. Chest x-rays are associated with radiation, although less than CT scans. So if the patient appears to be under control based on clinical features and serological findings, IgG4 and other findings in the blood, it's probably not necessary to image more often than once a year, and maybe not even that often. So I hope that all of that is helpful, and I want to thank all of you for joining in to our fireside chat today. Our motto is that improved communication, more education, broader support, earlier diagnoses, better treatments, wiser management will all help lead to healthier and happier lives for our patients. Thank you for joining us. Let me remind you again to follow us on our website, and please share your story with us on the homepage of our website. We look forward to seeing you again next month for our first caregivers conversation. Please keep the conversation coming through our website, and have a great weekend.